All right. Good evening, everyone. We're now live on YouTube, and this is our second headlines for the AANS CNS section on tumors. My name is Isabel Germano. I am the chair of the section, and I am very grateful. I'm very grateful to Dr. Panula and Dr. Nahed for chairing this event. I'm not sure what is happening.
We're good.
Keep going, Isabel. It's working.
You're good.
You don't hear it played back?
Mm.
No. Okay, great. So I just hear myself in my headset. That's great. So I'm very grateful to Dr. Panula and Dr. Nahed for chairing this, and I'm going to allow them to continue.
Susan, do you want to go first?
Absolutely. Absolutely. So welcome everybody to Headlines. And for those of you who didn't make the first one, the inaugural one, this is really a fun time for us to get to know each other. A lot of us know each other from email or from watching or sitting or whatever, but this is really a time to have everybody get a very brief glimpse of your personal and professional lives, and really for us just to get to know each other a little bit better, and therefore hopefully enhance our collaborative work. Brian, any other comments on that?
No, I just wanted to echo your sentiments and thank you to everyone joining us. The tumor section and specifically the executive committee is just this incredible group of diverse neurosurgeons from all over the world. And a credit to Dr. Germano for pulling this all together and for leading the charge of the committee. And thank you to the panelists today who are going to hopefully reveal a little bit more about themselves than all of us knew or cared to know. But the first one was awesome, and I really got to know folks in a way we hadn't before. So excited to see this to start. Should we, for the first pair, Gellery, do you want to kick it off?
Can you hear me? Sorry, my internet connection.
Yeah, we're good.
And do you need me to share slides or?
No, we would like you to introduce the person that was assigned to you by reading the title.
So you're going to read Garnie's first slide?
Yes, sorry, I'm just pulling those slides up. I somehow, my computer, my PowerPoint is not activating because I have to sign in. Is it possible? Because I can't get into my PowerPoint.
Yeah, you want to go to the second?
You guys want to go to the second pair?
Yeah, we'll go to the second.
Yes, my apologies.
Chaitin, will you introduce Kristen? Oh, wait, you're muted.
Yes, absolutely, Brian. Thank you. It's my pleasure to introduce Dr. Kristen Huntoon, who is a research fellow at the MD Anderson Cancer Center. She sits on the AANS CNS section for tumors on the executive committee, serving as the assistant editor for the newsletter. Very, very honored to be here with Dr. Huntoon.
Thank you for that introduction.
So now give me a second and we'll go back to the screen. Kristen, do you see your slides?
I see your desktop.
Oh, that's not good. Let's try again.
We're going to answer all your emails during this.
It looks very busy.
Take care of everything.
Perfect. Yes, now I see it. Well, thank you so much for letting me chat this evening about my work, and I'm excited to be part of the executive committee. So I'm a research fellow at MD Anderson, and one of the things I'm really interested in, as many people are probably on this call, is hopefully coming up with different ways of treating GBM. One of the ways that I'm interested in treating it is with a STING agonist. Excuse me. STING is a stimulator of interfering gamma genes. So it's a protein that's on the ER that can be activated by CGAS and CGAMP in particular. And its activation then leads to, as with every pathway, downstream effects. But in turn, it activates type 1 interferon and pro-inflammatory cytokines. And this is interesting to me because what we've seen with GBM, obviously, is that the T cell response does not seem to be sufficient for clearance of GBM. So the STING agonist that we used is 8803. The structure is shown in the bottom. And so we gave this STING agonist intratumoral injection. So it would be like convention-enhanced delivery of this agonist. And we initially started off with all these different combinations of adding it to anti-CD47, which is a do not eat me signal, and anti-PD1. But you can see in and of itself, the STING agonist 8803, which is the closed triangles, actually had superior effects than adding all these different combinations. And we verified it not just by survival, but by MRI shown in the bottom right-hand side, where you can see that any of the combinations that had the 8803 didn't have any tumor. And this was in collaboration with Mike Curran. He works with or was a postdoc of Jim Allison's, and so we're interested in activating STING. Not to get into it too much, because I know some people are talking about STING agonists systemically, but and their cytotoxicity and cytokine storm. But I think that STING agonists and/or other things I can talk about in a longer talk will be a great way forward in terms of GBM. And I think Dr. Hamburger had a great paper in Cancer Research showing that in a dog spontaneous model. Next slide.
I think we're going to pause for a second and see what your partner wants to ask of you.
Yeah, for sure. I love that.
Yeah, no, this is fantastic work. Obviously, very, very impressive preclinical data. What sort of things, Dr. Huntoon, do you think would be required to bring this to a phase 1 or 1/2 clinical trial in humans?
Yeah, I think that I think that Dr. Hamburger and Dr. Kern are already trying to work on bringing it to a phase 1 clinical trial. I think that we're just going to have to ensure, there's been some discussion whether the glioma cells themselves have to have STING, or if it is active on cells that are STING negative, because not all GBMs are STING positive. But without getting into too much, I think that it also has to do more with the immune cells and their activation of STING than the intrinsic expression of STING in the GBM cells. But I hope that it will be there soon. And there's some other players that hopefully I will someday get to be a part of those clinical trials as well.
Very exciting. Look forward to those trials being launched, and look forward to following the progress of this spectacular work. Thank you.
Thanks. Okay, so we're to tell you something about ourselves. So I just celebrated my 5th anniversary with my husband, shown here on the left. And that was obviously a picture from our wedding that day. And then we have a dog, Winston, who's shown on that green carpet in the middle. And we're to come up with 2 facts and 1 fiction, and you were to pick, I don't know, I guess the 1 fiction. So the ones that I have chosen are, I have ran marathons in 3 different countries. I can slalom water ski, and I have scuba dived with sharks.
All right. Do our audience want to guess which one would be the fiction? And the poll is now on the screen, so you guys can vote. All right. Thank you for voting. And Chetan, what is your guess? We have a split audience, by the way.
So. Oh,
nice. This is tough. I would say scuba diving with sharks would be the fiction.
No, I have scuba diving with sharks. I didn't think that people were going to think of it as in terms of neurosurgery, like being with sharks, but I have swum with sharks. I have tried to slalom water ski multiple times, and I have dropped it momentarily, but I don't think that I officially checked off that box as of yet.
Very cool. That's amazing.
Tough one. You got people really intrigued with this one.
Maybe this will be the year.
Okay, so now we're going to flip it around, and Kristen's going to introduce Chetan from his slide, and then he'll go on and present his professional and personal life to us.
Perfect. So it's my pleasure to introduce Dr. Chetan Betagada. We just talked about this and I'm sure I got it wrong. He's the Jennison and Novak Families Professor of Neurosurgery, Vice Chair, Department of Neurosurgery at Johns Hopkins University of Medicine. And he is the co-chair of the research section of Section on Tumors and Executive Committee. I'm really excited to hear your presentation and get to know you better.
I appreciate that. Really just an honor to be amongst this distinguished group of neurosurgeons and appreciate the audience taking the time to join us. A lot of the work that we do in the laboratory is based on detection of a variety of different cancers, and many of the guests today are also very much sort of steeped in the same line of investigation. So feel privileged to be able to speak on this topic with them present. This is a recent position paper by the Reno group that I had the privilege of being a part of, and really my reason for including this is just as neurosurgeons, we have such unique insights into CNS disorders and particularly neuro-oncology. And really what the position paper talks about is thinking about understanding biology in ways that we haven't historically done as part of our clinical trials. And what we really need is to be able to understand how these biomarkers, and our group is particularly interested in DNA biomarkers, but we know there are many protein-based, RNA-based, microvesicles, and all of these show tremendous promise. But really fundamentally, the reason I put this up is to sort of encourage folks as they conduct clinical trials, conduct studies, to keep in mind these ancillary endpoints. And so how do we understand? So Dr. Huntoon talked about a novel therapy. If that, when that enters into clinical trials, in addition to conventional MR imaging, clinical testing, survival, are there ancillary endpoints that we can look at in biofluids such as plasma, CSF, or others, depending on the tumor type, that may allow us to give insights that currently we're unable to identify. And so really incorporating some of these biomarkers, I feel strongly, regardless of which one is of interest to the group running the trials, I think starting to think about incorporating them the same way we do MR imaging or same way we do periodic neurological exams, I think is the only way to bring these variety of technologies into clinical practice. And so that's really my main reason for putting this paper up. And it's been really great to collaborate with many on this panel, as well as others along the neurosurgical community. So look forward to seeing this field hopefully progress to be able to actually help our patients on a daily basis. I'll pause here and see if anyone has questions.
This is something that I've always been interested in. I've been following this work for a while, especially, you know, when there's the neuro-oncologists are asking for whether it's progression or pseudoprogression. This I feel like would be a fantastic tool. Do you think that we're at the point that we can see either markers or changes in inflammatory conditions that we'd be able to see systemically if there's like an overreaction of the immune response so that we're seeing pseudoprogression, or do you think that's still a ways down the road?
Yeah, no, great question. I think certainly there are provocative data to suggest that indeed these tests, these liquid biopsy approaches would enable sort of decision making, and certainly no test will ever be 100% perfect, but certainly add additional data for the treating clinical team to help guide decision making. Certainly pseudoprogression is something that we all face, unfortunately, on a daily basis in neuro-oncology. Are we there yet? Probably needs a little more clinical validation and prospective studies to show utility. Are the technologies ripe and ready for these sorts of testings? I think they are, and certainly where we are today in terms of technology will not be where we are in 5 years or 10 years, but we have to start somewhere, and I certainly think that the time is right to start testing these very rigorously in a prospective interventional fashion. So I appreciate your question, Kristen.
Can I ask one other question? Do you?
Absolutely. Yeah.
Sorry.
Absolutely. No,
I am that person, unfortunately. What do you think about in terms of medications? Do you think like people will have to be off a window of dexamethasone or Avastin so that you're not having those factors
Yeah, great question. I think it depends a bit on what the analyte is. So what people are looking at. So presumably for certain molecules that are in circulation, medications have not been shown to be as impactful. But if people are looking at things like proteins or others that might be repressed or stimulated by things like dexamethasone, I think certainly that might be a consideration. But for things that are more perhaps DNA based that won't have as much fluctuation with things like dexamethasone, probably be reasonable to continue them on a clinically relevant dose. Yeah.
Great. So now we're going to move you to your personal stuff and fun facts.
Yeah. So this is a recent picture. My brother and two of my cousins, we went on a trip to really explore the northern outdoors, north of Saskatoon in Canada. We all really enjoy being outside and enjoying nature. And so we got together for the first time in many years this year. And this is a picture of me in the cockpit there, and we're flying really in a part of Canada that's inaccessible by roads. And so you really have to take these prop planes that land on water. And it was my first experience in that sort of an environment. It was just magnificent, beautiful, and shows the natural beauty of that region. So 3 little facts, one of which is not accurate. I'm a pilot, grew up in North Carolina, and we have a dog named Cosmo. So we'll take a moment for the poll here.
So the fiction is, the audience is 67%, 75% now on fiction being that you're a certified pilot. Kristen.
I don't know. With the photo of you being in the cockpit, I feel like it could be swaying me one way or the other. I'm going to go with certified pilot.
Yeah, actually, that's correct. That is a real picture of me in the cockpit, and it was a fun experience, but I'm definitely not a pilot. It's just these planes are so small, you kind of have to cram in. So the pilot was kind enough to have me, and we had a good time there. But I have a problem with heights, so I don't think I'd be the best pilot in the world. But it was a cool experience to just have that with some family and friends this summer. So yeah, 75% of people know me very well.
Well, thanks for sharing that.
All right.
Thank you, Kristen.
Geller, were you able to get up your slideshow and stuff on your computer?
Yes, I am.
Hey.
I actually just, hang on 1 minute. So do I go to Garnie?
Exactly. So you're going to introduce Garnie.
Okay, super. So it's my pleasure to introduce Garnie Vargodarian. He is an associate professor of neuroscience and neurosurgery at the Pacific Neuroscience Institute and Providence Health Systems. He is AANS and CNS section on Tumors Executive Committee, and he manages and oversees the newsletter as the editor for the section. And I think, Isabel, you have the slides.
All right, so I was trying to figure out what to show as an example of what I've done recently, and we do a lot of translational work and surgical outcomes data, but I thought this was an interesting paper because it was very apropos to the times. Basically, we published this shortly after the pandemic kicked off. Many of you were affected by the triage methods that we had to choose which patients to operate on and how to operate on them, and also which patients, where they would go after surgery. And I'm sure we weren't alone in the fact that our intensive care units were full of COVID patients, and we needed places to park our patients. So we actually had a little bit of a paradigm shift that I hope will continue. But basically, we moved to a little bit more of an outpatient approach to brain tumor surgery. And at the very least, some of our typical patients that were going home in a couple of days, 3 days, they all kind of shifted to a little bit earlier time. And here's our data. You can see on the right, these two panels show our length of stay for craniotomy and endonasal pre-pandemic, which you can see kind of averaged around 2 days. And then after or during the pandemic, we shifted over to about an average of 1 day length of stay. And you can also see our ICU utilization, which went down significantly, in particular with our craniotomy cohort, where pre-pandemic, we were like almost 80% going to the ICU. Post-pandemic or during the pandemic, only a third of our patients were going to the unit. So really allowed for us to open up beds for the other patients that needed them, and then also to get these patients through that were otherwise going to be delayed by weeks or months. And, you know, it was interesting. There was definitely a patient or family driven perspective that they wanted to leave the hospital as soon as possible. So we were somewhat blessed with that situation, which didn't occur before. But now that the patients and physicians and nursing staff are familiar with that, we continue this even though we don't have the bed crunch anymore, and we're still averaging around this time. And we hope that this will continue to be a progressive trend. And I would say it's very apropos that Geller is interviewing me, because a lot of this work was predicated on work from Mark Bernstein and those in Toronto that have really pioneered outpatient neurosurgery, and we're still trying to get used to it. But it goes to show that you know, it takes a little bit of pressure to shift your paradigm, and eventually, hopefully, we'll see some changes that are more pervasive and long lasting.
Super. Do I get to ask the questions?
You do, Gallery.
Okay, fantastic. Because actually, this is so practical, Garnie. I really enjoyed the presentation. 3 questions. One is, do you have the cost analysis associated with this as to what savings you make? Because I'm going to probably quote your paper in a meeting on Thursday that will help us with some, you know, resource pressure points that we're experiencing with nursing shortage as a consequence of the pandemic.
Yeah.
2 is, in extension to what you were saying, in an attempt to try and expand what we do as day surgery beyond, you know, brain metastases or more defined glial tumors supratentorially. We had attempted endoscopic pituitary surgery, but we had a couple of cases where the bounce back with the endocrine disturbance was considerable. So I wonder if you have data on those who actually perhaps were not managed the best with a shorter length of stay. And so what was the cause for return to the emergency department? And third is, it's interesting, you say that patients had that ambition to get out, whether you see that post-pandemic to still be the positive experience that they feel too, because certainly with the awake craniotomy that Mark started here, and then I in turn tried to translate it over back when I was in the UK, patients really have a decreased level of anxiety when you do qualitative studies, when you really make them realize that this is not a massive procedure that needs hospital stay, etc. So 3 questions. Biggest is the budget savings and costs with the data that you show, bounce back from complications, and then continued patients' positive experience. And thanks again.
Yeah, of course, and thank you. Well, I would answer the patient's perspective first. Yeah, there was definitely a lot of pressure during the pandemic to not even step foot in a hospital. But what we found was it was all the critical part was the preoperative discussion with the patient. And if you paint the picture that it's a short length of stay or it's an outpatient procedure, which we do some for our endonasals, actually very comfortably say it's an outpatient procedure, they're okay with that. It's the getting into the hospital and the nurses are saying, oh, you're going to be here for a few days, and then you come in the next day and said, oh, you're able to go home. all of a sudden that shock of, oh, they're kicking me out of the hospital type thing becomes a little bit more of an anxiety provoked situation. So that preoperative discussion was really helpful. I will say that there has been a bit of a shift back where some patients, and it's somewhat cultural in LA, and some of the cultures really want to stay as many days as possible in the hospital. They feel very secure there. So we are seeing a little bit of a shift back, but I would say the average is still better. And with a bit of preoperative guidance, I think that anxiety has improved. So hopefully we'll continue to see that. With regards to the cost question, we did not publish the actual numbers. I have the data if you want, but we felt that the numbers wouldn't apply across the board. Our math for our ICU versus our step down is somewhat different than somebody else's step down, but I can provide some of that data for you later on if you want, Gelera. But we do know, just ballpark, that average daily cost in the ICU is about $5,000. Whereas in our step-down unit is about $2,500. So if we can decrease our ICU length of stay, that's pretty significant cost savings. And then of course, each day is, the biggest driver of cost nowadays is labor costs. So each day they're in the hospital is a huge contributor to cost. And then finally, regarding the bounce backs, actually the bounce back issue we had solved thanks to actually Ed Laws and work from Gabby and others looking at hyponatremia. That was kind of the biggest reason, the number one reason after an endonasal surgery to have a return to the hospital was hyponatremia. And for many years, everyone was saying there was that 5% symptomatic rate that would bring you back to the hospital. It's probably 10% if you just looked at labs, but 5% that were sick enough to be readmitted with significant hyponatremia. So Ed's group published this maybe 4 years ago now, where they maybe it was even 3 years ago, where they basically just assumed everyone was going to have SIADH, and every patient was given a fluid restriction parameters of 1 liter, no matter what they look like on the day of discharge. And they were able to get their bounce back data rates down to 0. Which I think is pretty amazing to see a pretty consistent 5% rate per, over many decades to go down to 0. Others have tried to replicate this, and I think you're seeing occasional bounce backs. We implemented this protocol, and our bounce back rate has gone down to 0 specifically for hyponatremia. But of course, the postoperative, the occasional postoperative CSF leak or epistaxis or something would be a driver that we're also working on. But I can share that reference with you. And I think there's a couple of articles or abstracts that I've reviewed that showed that that's a pretty consistent paradigm. I'm open to hear what others have tried, but it seemed to be pretty successful for us.
Great. Thank you.
Okay, so a little bit about me. So the image on the left, that's my wife and my 2 kids, Sevan and RN. RN takes after me in that he hates taking his picture. So that's why he's not smiling. But I like, other than neurosurgery, I like to do a number of things in my free time, mostly outdoors type stuff. And I've really, especially during the pandemic, got bitten by the mountain biking bug. And this is actually a trip in Phoenix where Nick, Peter, and Elad and I did a quick mountain biking trip, which was nice and fun. But it's a good way to kind of, get out into the nature and try not to get stuck into the smoggy city of LA. And then many of you may know I graduated from the University of Michigan, so I'm a huge Wolverines fan. And if you open up my veins, you'll see maize and blue blood. But I'm trying to brainwash my kids early on, and this is us at a football game a few years ago. And my 2 facts and 1 fiction. I have a pathological addiction to online chess. I'm named after a pagan Roman temple in Armenia, or I can solve a Rubik's Cube in under 30 seconds.
Let's see what people think.
What's the world record for Rubik's Cube, though?
I think it's less than 6 seconds now.
So Garnie, we have 100% of the audience thinking that you're being able to solve the Rubik cube in under 30 seconds is the fiction.
That is correct. Oh, sorry, I should have let Geller guess. Yeah,
Well, I
I've,
kind of guessed by alluding to the fact of what's the world record. You can't be that close to the
Yeah,
world record, my
I thought
friend.
Garnie had it. I thought Garnie had the world.
No, I could solve a Rubik's Cube, but definitely not that fast. That's for sure.
It'd take me 6 months and I still won't solve it.
Well, the key is just to take the stickers off. You can do that in 10 seconds.
Exactly. You just got to
Or hand
be
it to one of your
master of
kids.
stickers.
Exactly.
And here's a little tidbit. I had previously Googled your first name, Garnie, to see if it was short for something or if it was something. So I knew it had something to do with a temple.
Yeah, I was.
Because it's not a typical Iranian name. So
No, it's a temple that was made as a gift by Nero to the Armenian king like a couple thousand years ago. It
yes.
looks like a mini Parthenon. All right. Should I introduce Dr. Zadeh?
Yes, please do.
All right. So I have the privilege of introducing my friend and colleague, Dr. Geller Zadeh. She's the Dan Chair and Professor of Neurosurgery at the University of Toronto. She's the head and Halpern Family Chair Division of Neurosurgery in Toronto Western Hospital, co-director of the Krembil Brain Institute at the University Health Network, senior scientist, Princess Margaret Cancer Research Institute. Professionally, she's a past president of the Society of Neuro-Oncology in 2022 and 23, and she's the editor-in-chief of Neuro-Oncology Advances. And on the AANS CNS Tumor Section Executive Committee, she serves as the education chair. And more personally, I've known Dr. Zadeh since I was introduced in the world of skull-based surgery, and I find her to be the triple threat, really an amazing surgeon, amazing researcher, leader in the field, and educator. And I'm privileged to be able to work with you.
Thank you, Garnie. That's very kind. Isabel, I think the animations still stay on this slide. So if you don't mind hitting forward a few times so that it populates it. Just my tumor highlights. I wanted to mention that I did my PhD in something fairly unrelated to where my focus is currently. I did my PhD on tumor angiogenesis. And when I started my independent practice, I wrote my first grant on identifying mechanisms of tumor angiogenesis beyond VEGF in glioblastoma, because that is the tumor that challenges us the most. And VEGF is 100-fold higher in glioblastoma compared to others. Two grant reviewers said in their response to my grant that the PI should focus on other areas because angiogenesis is dead. And that was really because the grant was written about a few months after the Avastin trials came out and showed negative results in glioblastoma, which was really, I think, a detriment to our field in general. Whenever we have a negative trial, the nihilism that's associated with trials, and we've talked a little bit tonight at this session, is a fairly big setback. And if you look at the field in general, the positive trial for glioblastoma, other than the two Stoop trials, the Stoop protocol that we all adhere to for the combined temozolomide radiation, and then one which has more controversy for the TTF treatment, there have been really no other positive clinical trials. So with that sort of a response for my PhD-based extension of research, I thought that I would divert more of my attention towards understanding the genomics of tumor biology, because that had been a very popular wave, I would say, when I started back in 2008, 2009 to start my independent research practice as a PI. And so the areas that I work on, you see on the left of the screen, are looking at peripheral nerve tumors, cranial nerve and peripheral. And we had a successful study for the genomic landscape of schwannomas, where in fact in this study, our key finding, I think, contributing to the field was to understand that there are differences in the epigenetic signature of schwannomas, depending on whether they start from the peripheral or the central cranial nerves. And more importantly, identify a fusion protein that is unique to schwannomas that's associated with worse outcome due to the more aggressive treatment of the tumors. And then the next areas of my focus you could see is on meningiomas, which has been quite rewarding for me, I would say, in the lab, as we've made discoveries to understand better the pathology and the genomics behind radiation-induced meningiomas from childhood survivors of cancer who receive craniospinal radiation, showing that NF2 is aberrant, but really the mechanism of aberrancy is distinct in some ways compared to the sporadic meningiomas because it's due to a fusion of NF2 gene with other counterpart genes. And then the most, I think, impactful work that we've had recently was the publication in August of last year, 2021, in Nature, where we show that perhaps there is a new mechanism that we can look at for classifying meningiomas beyond WHO grading, beyond Simpson grading, and other recognized models of classification, also beyond methylation, which is something we use in our clinical practice. And we've defined 4 distinct biologically relevant meningioma groups with distinct outcomes, as you could see, with the 4th group being the proliferative meningiomas, and the 1st group being the NF2 wild-type meningiomas, and the 2 in between being metabolic, and the next one being proliferative, have a very distinct outcome. And associated with them are genomic differences that can characterize them, but more importantly, the pathways and the biological pathways make relevance. Excuse me, the other one I said was proliferative is angiogenic. And then in order to be able to convert large genomic data sets to what could be applied to any clinical laboratory, we integrated proteomics into this analysis and used clustering of clusters and showed that there in fact are immunohistochemical markers that distinguish each of the one of the 4 classes that could then be applied to any institutional pathology laboratory. And then through single cell analysis, we show that the between tumor of different classes, the heterogeneity is fitting with the biology. However, the intratumoral heterogeneity is quite minimum. And so I think the impact of this work will come from additional data that we will in the future focus on being able to do really targeted therapeutics for meningiomas. And so instead of using checkpoint inhibitors for all of the subclasses of meningiomas, and ultimately, unfortunately, showing that the trial fails, we would do a more rational design where we would only use checkpoint inhibitors in the immunogenic population of meningiomas and hopefully show that there's a benefit. And then this next picture is the reward that comes with collaboration. This was a collaborative publication we had 2 years ago in Nature Medicine, where we show that the methylation signatures that are unique to every tumor can be in fact detected in the plasma and used as a biomarker. So an extension of what Chetan, Dr. Vargodarian was presenting. So next slide.
Well, can I
Oh,
ask
yes, sorry,
a couple-
Garnie, go ahead.
Yeah.
Yes, thank you.
Yeah. Well, Geller, I mean, of course, amazing work that you've done, and it's great to learn from the VEGF challenges from GBM and apply some of those for our trial design. I had a couple of questions for you. So first is, first of all, I've read this paper and really excited to see that we're making some headway in understanding the nature of meningiomas and how they differ. It was interesting to see that you noted that NF2 expression was actually due to fusion proteins, and I wonder if that would allow for potential drug targets down the line. As of course you know, these recurrent recalcitrant meningiomas are really tough to treat with any medication. And then the other question I had was more of a broader question. You're obviously, I think, leading the curve and establishing what standards are with regards to meningioma pathological analysis and incorporating methylation into your standard assessment. You know, it seems like in the GBM side, the WHO is starting to recognize that these are really genetically different tumors. Where do you see the incorporation of these from at that level? What's the typical lag time from introduction of such ideas and until it's accepted across the board?
Perfect. Yeah, thanks, Garnie, for that question. With respect to the NF2 fusion, just to clarify, we see primarily the fusion in the radiation-induced meningiomas, not in sporadic meningiomas, actually, interestingly. So although in sporadic meningiomas, it's either a point mutation or a loss of the whole gene or the chromosome arm, etc. In radiation-induced meningiomas, majority of the NF2 aberration was as a consequence of fusion, and their partner fusion gene was different for each of the cases. Now, the number of cohort that we had for the study, which was published in Nature Communications, is not large enough to say that maybe there are recurrent partner genes that were fused with the NF2. With respect to targeting it, it's a great question. There aren't any known existing drugs that would target an NF2 aberration. The gene is quite large, and it's tough to actually find a target product for it. And so it would be whether there is a fusion partner, but because it's not recurrent, it's hard to then identify a partner. There was 2 that had a recurrence. I'd have to refer back to the actual data that potentially could lead itself to being able to use therapeutic agents, which was relevant to PI3 kinase pathway. So hopefully that is the first answer. And then second is a super great question, because when I went through my training, and even early in my career, I assumed that once you make a discovery, there would be an immediate adoption of that discovery. And nobody in medicine, at least in my path, and others that I've spoken to through this experience, really recognize the major challenge and the barrier is in knowledge adoption and dissemination. So other than forums such as this, publications, repeating the same presentation to various institutions that have similar interest and appetite to adopt new advances for tumor diagnostic, classification, predictive modeling, there isn't another mechanism to really adopt it, because in order for some data to make it into WHO classification, for example, there needs to be a longer runway of data that's been published on the same material, number of different institutions that report the same finding, and then ultimately the WHO adopts it, though I have an asterisk to that in a second. So I think there is a bit of a challenge in how we adopt new discoveries. From our own personal experience, the methylation predictor that we have for meningiomas that was published in Neuro-Oncology took us approximately a year to be able to socialize the idea, educate the tumor board members, the radiation oncologists, medical oncologists, and others in the tumor board to really use this and integrate this into our clinical decision making. And now it's to a point where actually pathology and radiation oncology requests the predictive modeling for methylation. Yeah. So I think it's not a straightforward answer, and I think it takes some time. And sometimes in socialized medicine settings like us in Canada, policymakers are probably the best people that would be able to initiate that adoption of advances, because that would become what they would choose to fund and transition or sunset other tests, which is the level that we're at now in Toronto, where through our ministry, we're able to have methylation be adopted as a test and sunset the other tests. And so this will become a natural adoption of advances that we've made with methylation. But it would then have been about a 5-way runway. I think I'm being shown the next slide because I need to go to the next. Thanks, Garnie, for the question. I really wanted to just mention as my personal tidbit that without the teams of people that help me do what I do, none of it would be possible. And really, I rely through relationships that I build with my team members. On the top left, you could see the group are our surgical oncologists, who I was the head of surgical oncology for the first 5 years of my leadership role 4 years ago. And then the bottom left black and white picture are our neuroscience team that I'm the co-director for our Krembil Brain Institute. And again, a huge team of people where if you engage them and have people do different parts of the task, it becomes rewarding, but also possible. And then bottom right is my lab members. As you can see, a very diverse group. And I really owe everything that I show you and all of my research to every single member. They come together as a great team. The pandemic's impacted our ability to come together. This was, in fact, the February before we went into lockdown. And then most importantly, at home, I have 2 daughters, 14-year-old, and this lady here is now 2-year-old, who really tolerate my schedule. They're very understanding of it, and every free moment I have, I spend with them. I don't have my facts and fictions listed on a slide, but I have 3 points to make. So one is that 4 of the members on this panel have some connection to an Iranian background. Second is that I'm fluent in reading and writing Farsi. And third is I've completed my grade 6 piano.
All right, do we want to take a chance?
I suppose Garnie is biased in his answer.
I'm quite biased, but you may have thrown a curveball in there, and I'm nervous to select it. So I'm going to say it's the piano one is the fiction.
Wait till I play for you.
So the poll is 33% on each of the ones. So we really have no solution here.
Nobody knows who I am.
I didn't want to guess if you were fluent in Farsi. I was worried that, you know.
What is the answer, Gilroy?
I have not completed my grade 6 piano, though that would be a huge dream of mine come true. I do read and write in Farsi, though my mom would argue otherwise. And I believe 4 of us have Iranian connections on this panel.
Pretty awesome.
There we go.
That's great. Thank you again for this opportunity.
All right, so I think we have Gabe now, right?
Yes, I think I'm introducing my my colleague and friend. Let me just get this up here, but here we go. Okay, so Chris Cifarelli is an MD, PhD, MMM, Associate Professor of Neurosurgery and the Director of the Genomics Surgery Program at West Virginia University. He's also part of the Rockefeller Neuroscience Institute, and he's the brain tumor disease leader at WVU, an associate editor at the Journal of Neuro-Oncology, and he's on the executive committee of the tumor section, where he's the chair of innovation and technology committee. So Chris, you're up.
Well, thanks for the introduction. That's not my slide.
I just want to be sure that we're still all awake.
I couldn't do it justice, so.
I'm sure you do great.
Sorry,
Well,
but we changed the sequence, so I have to speed it up and go to the end.
Well, Gabe, thanks for the introduction. And just to bring more commonalities, not in ancestry, but in training, I believe half of the panel was also trained by Dr. Laws at one point in their career. So me as a resident at UVA and you two at the Brigham. There is a piece of that slide missing, and I don't know why. There we go. It was animated somehow. Okay, perfect. Thanks, Isabel. So it was kind of hard to track down one thing I'd like to talk about this evening, just in 3 or 4 minutes. But really, what some of my practice is focused on over the last 5 years has been incorporation and development of intraoperative radiotherapy, which is not necessarily a new technique, as I usually start out these talks by giving a history lesson that goes back to the times of Oscar Hirsch and Harvey Cushing. But in our current practice, we're utilizing intraoperative radiotherapy as adjuvant radiation for surgically resected metastatic lesions, as well as on clinical trial for newly diagnosed GBM. So the figure on the top left panel actually came from a review article that I published last year with Jerry Jacobson, who's the current president of ASTRO and our former chair of radiation oncology here at WVU. And it was meant to be a comprehensive review of the current state of intraoperative radiation modalities, and to draw a real distinction between what we're seeing emerging in interstitial brachytherapy, listed in the bottom right there as IBT, with the cesium tiles that are gaining more favor. And in our collaborative efforts, the driving force behind most of this was the clinical trial that we started working on with our German colleagues called Intrago, which there are a few centers in the U.S., but really the Central European cohort has been the major factor in trying to bring this into clinical relevance. But this figure in the middle is our 1-year local control rates, 2-year local control rates for the collaborative data we collected with 2 centers in Germany for surgically resected metastatic lesions treated with IORT, and we were happy to show that we had a one-year local control rate of 88% for these large resected metastatic lesions, which was at the time and still somewhat superior to what we could achieve in our practice with SRS. So as a new and emerging technology, we already heard there's some problems in trying to get everybody on board and adopt it, and we're still in the early phase of this. The intraoperative radiotherapy device has been around for a while. It's been utilized by our breast colleagues and widely publicized as a standard for breast sparing lumpectomy with adjuvant radiotherapy performed at the time of lumpectomy. But as we're moving forward in the CNS, we're doing work on the dosimetry comparisons with Gamma knife versus single fraction IORT versus 3-fraction IMRT. And the top right is a paper that Bill Small published in Brachytherapy for us last year, looking at the dosimetric differences. And more recently, we're doing some more neurophysiological studies. And the bottom left panel is a figure from a manuscript we're currently getting ready for submission, where we took a number of patients and performed real-time measurements while the radiation, before, during, and after radiation delivery, which is the first of its kind in humans to be able to do direct cortical measurements while radiation is being delivered in the field. So we're quite excited about this. We have colleagues in Central Europe that are doing this as part of an awake craniotomy, but not the radiation portion as awake. So this was really exciting data for us. In order to get people to really see this as a value to our patients population, we've spent a number of years, and for any of you who have done it already, realize that getting a new CPT code put through CMS is not a small task. And as of July 1st of this year, we have a new Category 3 code that'll be tracking this, so we can see who's actually utilizing it and try to get some more adoption from neurosurgeons out there in the field. It is a great benefit for our patients, and we heard a little bit about length of stay, but what we see for our rural patient population is this allows for consolidation of care for patients who travel long distances and are admitted with a symptomatic brain metastatic lesion that we resect and then consolidate their care and treat them with radiation as definitive treatment at the time of surgery. So they're not lost to follow-up, or worse yet, subjected to substandard treatments with whole brain radiotherapy where they might not need it. And we're following all these patients with an international registry that is open for all to participate in. And this is something from an innovative standpoint that we want to continue to push on our side. And I hope that the members of the tumor section that are interested in it may also try to see if it can play a role in their practice. So with that, I'll try to keep us on time, and it's hard to kind of consolidate 5 years worth of work into one slide, but that's the best avenue I can do. I didn't have any cover images from journals like Nature to put on there, but this will have to do.
Well, Chris, this is fantastic, and you don't need a cover from Nature. This is important leg work you've done here, and it's definitely an emerging therapy. So thank you for doing a lot of the kind of foundational work for this. Couple questions about it. So is WVU and your center part of the ongoing trial now directly comparing SRS for METs to brachytherapy at the time of initial resection?
So that is not with low energy X-ray. You're talking about the cesium tiles, correct?
So this is all X-ray intraoperatively low energy. Is that correct?
Yes, this is a single orthogonal delivery of low energy 50 kV X-ray delivery. There is one trial that's open, but only in central Germany, called Intramet. And that one is accruing patients, but we have not been comparing this on trial.
Okay. And is that a plan moving forward to get?
Honestly, the differences in what we can see in SRS versus IORT, I'm not sure what we might see on trial. It's the number of patients we would need to accrue to see significant differences is really going to be hard. we've talked to Zeiss, which is the manufacturer of the device, to try to sponsor something like that, but their interests are lying more in the GBM side, which we are participating in trials for GBM, and we're designing a recurrent GBM trial for use with 5-ALA and IORT.
Got it. And I'm really interested in the recording. What, just very briefly, what are you looking for with the recording? What's kind of the working?
So we were originally looking at delays or epileptiform discharges. But really what we see is that we don't see many changes at all. There's not even real delays there. And it just really proves the fact that, and we radiate our patients all the time, but no one's actually been able to cortically measure discharges in patients while external beam radiation is going on. And this just proves that the radiation really does not promote seizure-like activity in anything that we see in the recording. So it was really the belt and suspenders approach to proving that this is a safe technique, because we're getting more data to show it's effective.
Very interesting. Yeah, and a lot of people have talked about this neuronal tumor kind of network that may promote tumor growth. I wonder if it's an opportunity to look at that as well.
Yeah.
But really interesting. Yeah. All right, I guess we're going to your tidbits here. So
Yeah.
do you read them off for us here? So
sure. I don't know why that other AANS section Tumor Executive Committee sitting in the middle, but that's not part of the slide. So my personal tidbits, I'll just read them out to you. You can figure out which one's false. I own and operate a wine importing business. I've appeared in multiple karate magazines. This is embarrassing. Or that I hold a level B skydiving license. So A, B, or C. And I can't see the poll, so you'll have to.
The poll is coming in, and so far we have 50-50 on number 2 and 3. Now we're a third, 1, 2, and 3. And it looks like most of the participants have voted. So we're really split 1/3, 1/3, and 1/3.
And nobody knows me either.
I don't really know, Chris. I see you as having a wine business and having a background in karate. So I'm going to go with the skydiving one.
Well, that is an excellent guess. So yes, I do own and operate a wine importing business that started when I spent my year in Auckland, and I continue to do that. And there's some of the wines that we import. I have appeared in multiple karate magazines. That's a cover of one right there. Of course, they were in 1981 when I was 5 years old, but it's a fact. And no, I see no reason to jump out of a perfectly flyable plane. And what you had back there on that slide, if I could just, if Isabel, you bring it back up, is 2 views of the same place. One is, so the one right there on the right is actually a view of Kent Island in the middle, Chesapeake Bay, and the view on the left is actually from the boat that we take out from that point right there on Kent Island. And I'm much more comfortable in trying to swim for my life than fly for my life. So yeah, you got it right.
So maybe Chetan can fly a plane while you jump out of it.
There you go. There you go.
That end really badly for everyone.
And I can play you the piano.
So I have the pleasure now of introducing Dr. Gabriel Zada, MD/MS, who is currently the professor of neurosurgery, otolaryngology, and medicine at the Keck School of Medicine at USC, where he's also the director of their Brain Tumor Center. Currently, he serves as on our guidelines committee for the tumor section, and as I said, a great friend and colleague. So, without further ado, Gabe.
All right, thanks, Chris, and I'll try to keep us on time here. Are the slides coming up? Or do I need to bring up my own?
The slides are coming up. The computer is just taking a side tour here, but it's right here.
Well, this is great. Thank you, Susan and Brian and Isabel, for organizing all this. And it's good to see you guys. I'm going to talk a little about some work we've done with 5-ALA recently, and just trying to kind of push the envelope. We're a big 5-ALA utilization center, and we started with the microscope when it became FDA approved. And then I got my hands on a blue light endoscope, which is urology equipment that we repurposed, of course, with patient consent and IRB approval. And it's not an HD scope, it's a standard definition scope, but the benefits are you can put it deep in the cavity and look around corners with angled lenses. And Isabel, will the video play there by any chance? It's the bottom left panel, or is it not playing? All right. Well,
It's
maybe.
playing.
Okay, good. So this is just an example case. This is a left frontal high-grade glioma. We started with a microscopic technique.
No, sorry, it's not playing.
Doesn't play. Okay,
No.
well, it's okay. The main points are in this article we published in the JNS, we had 30 patients. When we did biopsies through a very small port, this is like a 9mm port, we would put the blue light endoscope through the port and we would biopsy only fluorescing tissue. And it was 100% positive for glioma. We don't even wait for our pathology to confirm anymore. If it's a suspected glioma, we just biopsy the most fluorescing region. And then we did a variety of microscopic cases that we converted at the end to endoscopic assisted cases, and some exoscopic to endoscopic cases. And in every single case, there was more fluorescence with the endoscope than the microscope, likely because we're delivering the light source into the cavity. So much more avid fluorescence. And then again, the use of the angled endoscope vis-a-vis a microscope, which is a direct line of sight, we think can help look around corners and show potentially hidden tumor areas. So I wish I could show you the video, but for some reason it's not. Well, actually, can I just share my screen, Isabel, real quick?
Yeah, try that, Gabe.
See if it works. So this is the heads-up comparison. On your left is the microscope. Sorry, on the left is your endoscope. On the right is your microscope. And just an example of more avid fluorescence here as it proceeds. Again, endoscope on the left, microscope on the right. And in every single case, we saw more avid fluorescence. We're trying to quantify this, and it needs to be validated in terms of whether increased extent of resection will benefit in terms of progression-free and overall survival. But we at least think that delivering the light source into the cavity may offer a benefit. So that's all I wanted to share here. And then on to my personal tidbit.
Oh, wait, I got to ask a question, don't I?
Go ahead. Oh, yeah, question. Sorry, Chris.
Yeah.
Go ahead.
So great images, great talk. I think it's somewhat frustrating that it's taken our U.S. centers so long to incorporate 5-ALA compared to what they've been doing in Germany for so long. What do you think its utility is? I mean, for extent of resection, great. Do you think that there's a big difference in novel GBMs and high-grade gliomas versus recurrence? Have you done any of these in recurrence, and is the fluorescence considerably different?
I haven't quantified it, but it's still very helpful on recurrent cases. Of course, you have more scar tissue and radiation-induced disease that can mix the picture. And we're learning now that there are some normal structures that fluoresce. The ependema is a good example that you have to be mindful of, but we still find it very useful in recurrent cases.
Great. And the hippocampus fluoresces too.
Yes, that's a great example. Choroid, hippocampus, yeah, absolutely. So we have to learn more about that, so it keeps patients safe, but definitely a lot of promise there.
Thanks.
So my personal tidbit, I couldn't be more proud. I had a baby daughter born just about a month ago, 5 weeks ago. This is Harper, love of my life, and so things have been fantastic. 2 facts and 1 non-fact. I have 3 cats, Athos, Porthos, and Aramis. I'm the first in my family to attend college, or I'm a New York Times crossword puzzle fanatic, and my current streak is over 200 days.
I'm gonna have to pick the 3rd one, just because you did just have a daughter, and I can't imagine that you kept up your streak of the crossword puzzle through the birth of your child. But that's my only basis for saying that. So
and the audience is agreeing with you.
The audience is agreeing.
No, sorry, wait. There is now some respondents going for number 1.
I was going to say, Chris, you're calling me a cat lover, huh? So
there's worse things to call people. I mean.
I'm just kidding. The answer is 1. I don't have cats. I have a dog named Finch, and I am a New York Times crossword fanatic.
Well, I commend you for keeping it up through the birth of your child.
It's been hard, but it's the one thing I do at night before I go to sleep for my mind.
And congratulations to our audience people that were able to pick number 1 and being correct.
Yeah, impressive.
Your daughter's beautiful.
Thank you so much.
She's a cutie.
Thank you. I agree, but I'm biased, so.
Oh, she's cute.
All right, so we're, I guess, only 5 minutes over, but that was fun and definitely worth the festooning into the extra 5 minutes of dinner time or lunchtime or whatever time zone you guys are in. So Brian, I guess we'll wrap it up and just thank you guys so much. Isabel, this was a brilliant idea. It's both times it's been really fun and really a pleasure for us to get to know you guys better. Brian?
Yeah, thank you again to everybody. It was fun learning, and I'm sure I'm going to be thinking of you differently next time we're in a committee together. Have a good night, everybody, and thank you all for sharing. This was really awesome.
Yeah, Nate, guys.
Take care.